Our next speaker is Professor Bola Owolabi, who's the director. I think many of us will know who she is as well. Director of the National Healthcare Inequalities Improvement Programme in NHS England. And Bola couldn't make it, but she's online, I hope. And I hope.
Hi, I am here.
Fantastic,
Hello.
Bola.
I can see you all, but I don't know if you can
brilliant.
see me.
It's great to have you. So thanks for joining us.
Hi, Cameron.
Hello. Right, so we've got a great group of people here. They're very engaged, ask wonderful questions. So just to say, Bola has kindly agreed to take some questions at the end. Is that right, Bola?
I will do my best. I have to be off at 2.
Okay.
But I'll do my best.
Okay,
yes.
We'll try and squeeze some in. So get rid of your questions. Bola, over to you. We look forward to it.
Great. Well, thank you so much, and thanks for accommodating my request to join you online. I'm here in Leeds, where the executive team of NHS England is meeting with the senior leadership team of the organisation. So I'm incredibly sorry that although my wish was to be with you in person, it has to be online because we haven't yet found a way of cloning ourselves. So thanks for indulging me. Good afternoon, everyone. And let me have a go at sharing my screen. Wish me luck. I hope it works. I can't quite see what I was hoping to share with you just now, but colleagues from your end have said it might be easier if I shared my screen. And so I'm trying valiantly to do that for you at the moment. I don't know if you can see that yet, Cameron. Can you see my screen?
No.
Not at the moment.
No.
I suspect not. Okay, let's have a look here. Let's try this for size. Can you see this?
Yes, we've got you. Well done, Bola. Yeah.
Excellent.
Well, we need your IT skills here. Can you just transport yourself to London?
It's more
over to you.
It's more a product of fortune than expertise. I can tell you that now. So thanks very much for having me. And look, I think when we have the conversation about health inequalities, many of you will have heard me say that I prefer to start from the place of possibility. And if you would allow me, I will start, as I always try to do, with the vision that I believe we are all trying to achieve. And that vision is exceptional quality healthcare for all. And you will notice I underscored for all. And I do that because I want to particularly bring people in the room that we inadvertently leave behind, even when we say for all. And that is why it's underscored. And that we're going to achieve that vision by paying attention to the 3 biggest dimensions of inequity. And that is equitable access. And I'm not talking about equality of access, because equality assumes that we all start with the same starting point, and that we don't necessarily need to make adjustments for certain people and communities. So it's equity of access rather than equality. And also that we are mindful that people's experience matter, especially if you are already suffering disadvantage of various types. And that it is the combination of equity of access and the excellence of people's experience that hopefully will combine to yield the optimal outcomes that I believe we're all trying to achieve by virtue of being in this room together. And so going from the vision then, I just want to maybe spend a little bit of time to just very quickly just remind us of why all of this matters, and to talk about the people cost of healthcare inequalities especially. I found myself reflecting over the last few days about the fact that without population health equity, we will really struggle to achieve population health security. And we saw that very much during the pandemic. It was a matter of nobody is safe until everybody was safe. And suddenly we all realized that just being cozy in the comfort of having access to the vaccine was actually not keeping us safe. Because as long as there were the global majority that didn't have access to the vaccine, nobody was safe. At the moment, we're talking about Mpox, for example, and yes, Thank goodness we don't have any case in the UK at this moment in time. But of course, we can't be complacent, because as long as there are people who are ravaged by it, we can't consider ourselves to be safe either. And so the people cost, therefore, I'm looking at it from the perspective of how it costs us as a whole society and how it costs the particular communities that are most affected. And we saw that during the pandemic. You all know that, as I've said many times before, we weathered the same storm of the pandemic, but we most certainly didn't weather the storm the same. You only need to look at who was more likely to contract the virus, who was most likely to be sicker once they got the virus, and who was more likely to die. And so weathering the storm was not the same thing for everyone. But there is a danger, of course, that we think it was the pandemic that caused health inequalities, which would be an absolute fallacy. We went into the pandemic with some of the stark inequalities of the fact that somebody with a learning disability who also happens to come from an ethnic minority background, their life expectancy is only 34 years. And if you're homeless and you're a man, your life expectancy is 43. If you're a woman, it's 45. If you live with serious mental ill health, then you have a life expectancy that is nearly 20 years shorter than everybody else. And if you're a woman who is born in Blackpool, then your life expectancy overall is nearly 10 years shorter than a woman born in the more affluent parts of the country. Those were the numbers going into the pandemic. What the pandemic did, though, was to exacerbate pre-existing health inequalities. It cast a very harsh light on them and made it impossible for us to ignore. But the other thing that I just want to talk about is the business case for tackling health inequalities, because there's a risk that we think this is just a moral imperative, and that it's just an ethical argument. But actually, it costs us. It costs us economically, and the Institute for Health Equity, these are old numbers, by the way. This is going back to 2010, these numbers. And I'm sure that if we were to have a more current estimate of what these numbers are, they will have gone in the wrong direction. So in terms of direct NHS treatment costs attributable, to health inequalities, they were telling us at the time that it's in the order of more than 5 billion. And if you want to know what sits behind that number, it is the fact that long-term conditions, for example, the burden of ill health is not borne equitably. So if you look at the Health Foundation's report, Health Inequalities in 2040, we know that 80% of the rise in the burden of ill health we are going to see between now and 2040, 80% of that rise will happen in the bottom 5 deciles of the population. So people from our most disadvantaged communities, what does that mean? They develop long-term conditions earlier, accumulate them faster. That translates into higher prescribing costs. It translates into unplanned admissions. It translates into delayed discharges. And it translates into more procedures to deal with those issues. For example, diabetes complications. Those are the factors beneath that headline 5 billion number. That is the direct NHS treatment cost. What about the economic cost from a societal point of view? They were saying that the productivity losses was around 31 to 33 billion. What makes that number up? People's exit from the workforce. At the moment, we're talking about the fact that the overarching mission for the government is the economic growth mission. I put it to you that the economic growth mission is only successful to the extent that the health mission succeeds. And the productivity losses are because of the earlier exit from the workforce as a result of the burden of ill health. So people's ability to contribute to UK PLC is inhibited and curtailed by the disproportionate burden of ill health in our most economically disadvantaged communities. What about the loss of tax revenue? They're putting that between 20 and 32 billion. So when you exit the health economy, or in fact the wider economy earlier, it's not just the exit and the cost that brings in terms of productivity loss. It is what we lose in terms of the tax revenues that we now cannot gain by the virtue of your exit from the workforce, and also the higher welfare payments that we have to make as a society. And when you consider what I said earlier on, that our most socioeconomically disadvantaged people have a shorter life expectancy, we actually spend more per capita in healthcare expenditure for those shorter lives. And that is the reason why I think increasingly we need to also be making the business case for why we need to tackle health inequalities. What about the intersection with patient safety? So this report was showing us how, for example, people being digitally excluded, or people for whom English is not their first language, or people with learning disability who suffer what we describe as diagnostic overshadowing, whereby everything that is wrong with you is because you have a learning disability. And as we saw from the Oliver McGowan case, sometimes there is something else going on that is nothing to do with your learning disability. And we all know from the Embrace data about the maternal mortality gap, the fact that Black women are 3.8 times more likely to die in childbirth. You look at NHS resolution and what we pay out in terms of claims when things have gone wrong. Actually, health inequalities are costing us, even from the point of view of patient safety. It's costing the individual, but it's costing the healthcare system. As a GP, I have the privilege of receiving from the Medical Protection Society, MPS, a booklet every quarter that tells me how much the NHS has paid out on patient safety incidents. And if you imagine us replowing all of that back into patient care, the difference that it can make. So health inequalities is costing the individual, it's costing society, it's costing the economy, and it's costing us in terms of patient safety incidents and the economic impact of that on our healthcare service. And so on several levels, health inequalities is not a niche issue, it's absolutely mainstream, is the point that I'm trying to make. And for those who say, but it's so complex and we're never sure where to start, that is what Core 20 plus 5 is trying to do. It's an excuse remover. It's a place to start. Core 20 plus 5 is absolutely not the panacea. It's not the silver bullet. But what it does is it moves the narrative on from that which we can't do to that which we absolutely can do. And so Core 20 plus 5 is a framework to galvanize and focus effort, energy, and investment. What we're saying is we need to identify who our Core 20 plus population group are. The Core 20 are the 20% most socioeconomically deprived by the index of multiple deprivation. The plus are the people who tend to be missing from the data despite everybody's best effort. Coastal communities, ethnic minority communities, nomadic communities, our Gypsy Roma traveler communities, for example, people in the justice system, people experiencing homelessness and rough sleeping. We're saying they're the plus. Look for them in your local communities. And once we know who the Core 20 plus are, that we drive relentlessly behind these clinical areas that are the biggest drivers of mortality inequalities: maternity, serious mental illness, chronic respiratory disease, cancer, cardiovascular disease, and across the 5, smoking as the common denominator of inequity. What about children and young people? It's the same 20 plus population group, but the clinical areas are different because it's not about mortality, it's about the difference in access to care and the worsening of outcomes. So it's about asthma, diabetes, epilepsy, oral health, and mental health. And in relation to oral health, when you consider that the biggest reason why children aged between the ages of 6 and 11, the single biggest reason why children in that age group are admitted to NHS hospitals is for dental extraction, is to remove their rotten teeth. This is 2024. We are an advanced economy. And I can't believe that I've just said that. And the prevalence of dental decay at the age of 5 in children from our Gypsy Roma traveler communities is 60%, 60. And that for me is, I'm just trying to make the case that this is an opportunity for us to absolutely focus our efforts. We've all read the Darcy report that was published last week, and you will notice that it talks about health inequalities from the first paragraph and through every single service line in that report. And my question to us is, so what? So what is the fact that we've built a delivery ecosystem to turn Core 20 plus 5 from a pretty infographic on a page into something that is actually real and tangible in people's lives. And we are putting innovation absolutely at the heart and the center of the core 20+5 delivery infrastructure. And so what does that mean? There is something about the power of innovation to address healthcare inequalities. And I just want to talk you through a few examples of how we need to build an equitable innovation ecosystem. It goes all the way from research and audit. So when we design our audit processes, do we construct the audit in such a way that it tells us the story of what is happening by socioeconomic deprivation, by ethnicity, by deprivation? In terms of research, when we look at our research pipeline, what is missing from the research pipeline? What about our research panels, the decision-making panels for research? What is the constitution and the composition of those panels? What about the inclusion of communities that tend to get left behind, the clinical trial participants? How about when the product pipeline has actually been made, equitable access and uptake of products that come through the research that is funded from our collective taxes? And what about regulation? So the role of NICE. NICE has been doing some absolutely fantastic work. Some of you have seen Voxelotor approved for the treatment of transfusion-dependent sickle cell only in the last few months. You may have seen that Casgevy, which is a gene therapy for people with major group B thalassemia. We are the first nation in Europe to make Casgevy available on the NHS for people with group B beta thalassemia major. I'm just giving you examples of the power of innovation to begin to reach the margins of society, but we need to be intentional about creating an equitable innovation system. And so I just wanted to give you that example. How about working with the voluntary sector and the voices of those communities that tend to get left behind? The way we commission, the way we adopt these services, you know, the whole thing across the product pipeline, from concept to design to implementation and evaluation, and building health equity across the whole product pipeline. You know, some excellent work happening, as I've said, at NICE. Also the small business research innovation in NHS England, the clinical entrepreneurs program, the health innovation networks, as they're now called. They used to be AHSNs. We're working intensively across all of those to make sure that health inequalities is not a niche idea. It is something that we're building into the heart of innovation, creation, and development. And I just want to talk here about the Innovation for Health Inequalities program in HIP, working with our Accelerated Access Collaborative partners and the health innovation networks. What we did there was to say, across these 5 clinical areas in core 20+5, let me use cardiovascular disease as an example. Are we reaching the core 20 plus population group? For example, inclisiran, which is a lipid lowering medication to reduce the risk of heart attacks and strokes. When you looked at the uptake of inclisiran, the uptake amongst the populations that were more likely to get strokes and heart attacks was really low. But through the investment we made in INHIP, our ICBs, working with their health innovation networks, went to the core 20 plus communities to ask the question, what is getting in the way of you taking up these products that will reduce your own health risk in a respectful way? And we saw the uptake rise. You know, Greater Manchester is an excellent example, where by the end of the year, they saw the rise in inclisiran uptake. And that was true across many product pipelines as well. So I'm just going to leave it here because I think the richness is usually in the conversation in these things. I'm just making the point that in terms of innovation in relation to products and innovation in relation to approaches, the methods that we use to try and reach underserved, seldom heard communities, are we orientating the commissioning, the investment in innovation in a way that differentially targets the communities that get left behind? And I'll say to you that the biggest gains are at the margins. If you consider that most of the economic inactivity that is leading to our loss of productivity nationally, most of that economic inactivity is being driven by ill health, but the burden of the ill health is being borne disproportionately in our most socioeconomically disadvantaged communities. So if I had something to say about it, I would be saying that we differentially invest our energy, our time, and resources in supporting those communities that are easy to ignore, seldom heard, underserved, they are not hard to reach. And in doing that, we will get the bigger gain for our bucks, because the biggest gains are at the margins. By definition, it is, because of the incidence and the prevalence and the distribution of ill health. So I'm just going to stop there, because that's just the case that I just wanted to make. And that leaves us about 5 minutes for us to hopefully have a conversation and questions. I'll leave it there. Thank you.
Bola, thank you. That was a tour de force. Fantastic. Well, I could do that again, I think. Okay, I don't know which way to turn, to look at you or look at everybody else here. But I'll get questions from the audience. Who's got a question for Bola? I mean, I was interested that we now have at least 2 ways to fill Rachel Reeves's black hole of 20 billion. So perhaps she should be in this audience. She'd have all the problems solved. Right, a question from the audience. Okay, well, I've got a question for you while you're all thinking. Bola, you spoke about research and funding. I mean, we have some very big funders in the UK, like Wellcome and etc. What are you doing about getting them to consider inequities and inequalities in their funding strategies?
Thanks, Cameron, for your very kind remarks. Look, I want to give a huge shout out here to Professor Lucy Chappell, who is the Chief Executive Officer of NIHR. NIHR have been doing some absolutely stunning work in this space. Many of you may have noticed in March this year, they launched their 50 million maternal health inequalities research grant. Last year, you may have caught up with the HDRCs, which are the health determinant research centers, where they've been investing 55 million pound tranches for 13 local authorities at a time to look at the social determinants of health that are driving health inequalities. They developed and published the Include framework, which is intended to increase the diversity of clinical trial participants. Yeah. And I think what the NIHR have done is to set an absolute blueprint for other research funders to follow in terms of how you reorientate the funding to specifically address health inequalities. I just wanted to give that huge shout out to NIHR and the work that they're doing in this space.
Yeah, so your message is really that there is a template there for Wellcome and other people to follow.
Absolutely.
That's what you're saying. Yeah. Okay, got a question at the front. We'll bring you a microphone.
Thank you.
And so with the last minute, everybody's hands go up. All right. Okay, go.
Okay. This is Geeta Nagun. Bola, as always, very powerful indeed. Yeah, we miss you in the room. Look, you mentioned about in research and innovation as well, about NICE guidelines and also the health inequalities portal. But what we really need, Bola, is not just what is there in their portal, but actually NICE guidelines for populations that are at high risk, and to identify and create guidelines specifically for those groups so that we have those guidelines. Otherwise, it's just so difficult to get funding from ICBs to achieve those results.
Lovely to see you, Geeta. And just to say, again, thank you to Sam Roberts and her team at NICE. So, for example, the homelessness and inclusion NICE guideline is a great example of exactly what you've just said there. They've done that, and I think it's really about how do we work together to turn it from a guideline to reality. And the other thing they did, which I was talking about in my speech earlier on, is don't underestimate the power of what they did in getting Voxelotor over the line and Casgevy. Without taking that health inequalities factor into consideration, we will absolutely have struggled, to make these life-saving, not just transforming, but life-saving therapies available to people here in the UK. And the number of messages that I got when Casgevy went live on LinkedIn was just unreal, from all over the world, people saying, how have you guys done that? So I think those are tangible examples of NICE absolutely putting its stamp on health inequalities. Of course, I agree with you. There's always much more that we can do, but I'm heartened by the fact that we are making great progress because of the leadership of the likes of Lucy and Sam and their team.
Fabulous. Bola, thank you. Do you have time for a couple more quick questions, Bola?
Two very quick
I'm
ones.
sure they couldn't start without you. I can't imagine that. Okay, we've got a question here. Oh, one there, and then we'll go across. Yeah.
Hi, Bola. I just wanted to ask you, and this is with me with a chess brain here. I always plan a few moves ahead. With Core 20 connectors and all the programs that you're running, and I noticed that you've got the ambassador program that is going to be shutting down soon, about 20th of September, so everybody apply if you can. What is the next step after that? You get the innovation, you get the funding, and then what? Do you have any examples of how people have managed to continue the good work after the funding has ceased?
I think it's a great question in terms of the so what, and what I'm arguing for is the hard wiring and the mainstreaming, so that it's not just depending on funding from the centre. So a quick plug, two things. The whole NHS budget has got a health inequalities weighting in it, both for primary care, secondary care, and specialised commissioning. That's the first thing to say. There is a health inequalities weighting in it. The second is to say there is a health inequalities adjustment in every ICB's allocation baseline to the order of 200 million, which is needs weighted. The question is leadership. It is about the courage of our conviction to use the funding for exactly the purpose that it was intended. So there is no use me and my team and others making the argument from the centre and ensuring that these funding streams are absolutely there, and then for it to be used for something else when we get out into the wider system. So I think I'm going to put the challenge back to the system to say the investment is there. We need to summon the courage of our conviction to say, do you know what? In the face of the headwinds, we will always do the right thing by the most marginalized, because it's the morally and ethically right thing to do, and it costs us when we don't do it. That would be my response to that.
Very good. Thank you. We've got one more question. Actually, leadership we're going to talk about later on.
Okay, thank you, Professor Bola. I'm Zainab from the Stroke Association, Health and Qualities Lead. My question is around the role of the voluntary sector. So you spoke about us as being an important part in addressing health inequalities, but what is the role of the NHS in empowering the voluntary sector and particularly local community organizations in actually addressing health inequalities? Are there plans to upskill or just build capacity in this space? Because I know a lot of work is being done within the NHS to upskill clinicians and other members of the team to be more aware of health inequalities, cultural competence, and so on. But what is the role of the NHS in also doing that within local community organizations, and even national organizations as well, so that we are more learned partners to helping to drive forward the work of the NHS?
Thank you. Great question. Three things. One, that we recognize the VCSE sector as a phenomenal source of actionable insight. You have far greater reach into the communities than we ever will have. And so when we designed the Core 20 Plus Connectors program, I insisted that actually the recruitment of the Core 20 Plus Connectors must be led by the VCSE sector, because I know that you have greater reach into the community than me and my team sitting in Wellington House in London. So I think that that's the first thing, is respectfully acknowledging the actionable insight that you bring to help us to target our resources appropriately. Then the second point in terms of capability building, you're absolutely right. So two things we've done. The Core 20 Plus ambassadors, and thank you to the colleague in the room who gave a plug for that. The current recruitment, it closes very shortly. On Friday. So the current call for Core 20 Plus ambassadors, we've deliberately targeted it towards the voluntary sector, precisely for that reason. And the third thing that we've done is we've commissioned the King's Fund to actually develop a civic leadership training course for the VCSE sector on how to lead for health equity. So it's those three things really: respecting your voices to guide us in the right direction of where to put our investments, building your capability in the way that you've just said, but actually making sure that you are part of the delivery ecosystem of things like Core 20 Plus 5 through the Ambassadors Program. So those are the three reflections I have, but I'm sure it's much more than that if we had time.
Bola, thank you very much. Thanks for sparing the time.
Thank you for accommodating me to join you in this way.
You've been amazing. You weren't here, but your energy and passion made it feel like you were. So we appreciated it. Thank you so much.
Thanks all. Thank you.